I introduce Professor Thomas Churchill to this lecture series. I'm extremely grateful to him to consent to join this series, and coming from Imperial College of London, I think which we can expect only excellence from these institutes. So Professor Thomas is a disease dynamic expert and a mathematical modeler. He's currently affiliated with Imperial College of London, where he specializes in malaria research and has developed transmission dynamics for malaria. I welcome you here for this lecture, and not taking more time, over to you, Sachin, and over to the lecture. Thank you once again.
Okay, thank you. Before I invite Tom to start, I welcome all the participants, all the esteemed guests, and of course Thomas. This is our second lecture series on infectious diseases, and this is the 7th lecture. And the lecture is special because this is the untouched area which we have not covered yet, which is very significant for us and plays a very important role in elimination goal of malaria from India. And Thomas has come with a diverse and mixed experience, as he's an entomologist, parasitologist, and mathematic modeler. He's a well-known figure in mathematic modeling. I have heard a lot of good work from some of my colleagues. And he works pretty closely in Africa. He's currently affiliated with Imperial College London, as Dr. Rahi mentioned, and he specializes in malaria research. He's a vital member of a diverse team of scientists who have developed one of the most widely recognized transmission dynamics model for malaria. This model has generated significant attention, have been featured in more than 90 scientific publications, and has played a crucial role in supporting policy decisions, including those of the World Health Organization Malaria Global Technical Strategy. In the recent years, Professor Churchill has taken the lead in developing vector control components of the model. He has been at the forefront of evaluating the effectiveness, both established and innovative inventions targeting mosquitoes as an essential aspect of malaria prevention. His primary focus lies in comprehending various threats to malaria control, such as emergence of insecticide resistance. He actively collaborates with the public health organization, industrial partner, and increasingly engaged with the international donors and national malaria control programs. This collaboration aims to optimize malaria control strategies in real-world setting, drawing on his expertise and the insight gained from the model. So with this brief introduction, I invite Tom to start the talk. And one more interesting thing is he collaborates with NIMR, which is not National Malaria Research here, but this is National Institute for Medical Research in Africa. So just to avoid the confusion, I wanted to mention this. Yes, Tom, all yours, please.
Thank you very much. Thank you for a very great introduction. And yeah, sorry, there's other NIMRIs in this talk, but not your own. But I'm very happy to talk to you today. You know, as a mathematical modeler, we are nothing without talking to the real experts in the field. So I'm really excited to talk to everybody, but specifically, to kind of learn from the kind of vector biologists in the room, because effectively what we do is we are, as I'm going to try and explain, is we're trying to use mathematics as a tool to help decision making. However, there's an awful lot that can be overinterpreted, and so hopefully I'll start talking about how we can understand the data and how we can use the data and how we should use these models, but not overly use these models. And today I'm going to mostly be concentrating on work in Africa, but there's lots of parallels to what's going on in India, and there's a whole heap of very interesting vector controls that we'll be hopefully looking at into in the near future. So as it's a diverse audience, I just thought I would have a few introductory slides. When I can start playing. Go. So just to remind everybody that I'm mostly talking about malaria and falciparum malaria in this situation, which is certainly the parasite that has the greatest public health impact. And I work in the department of infectious disease modelers. There's COVID modelers, there's HIV modelers, and I don't think any of the life cycles are quite as complex as the malaria life cycle that they have to deal with. So we have to deal with the parasite inside the human, and malariologists love lots of different names for the different parasite stages. We have to deal with a parasite in the mosquito because malaria is transmitted from person to person by a mosquito. And so we have to capture all of these interesting dynamics which are going on. The interaction between human and the parasite, the interaction between the mosquito and the parasite, the interaction between humans and mosquitoes. And so it's a really interesting forefront of the battle of evolution, and it's obviously got huge impact on public health. So just a bit of a summary of where we are with malaria at the moment. Every year, the WHO produces the World Malaria Report, which is reporting the level of malaria from the previous year. So the data we're currently presenting comes from the World Malaria Report in 2022, so showing data up to 2021. And what you can see is at the bottom here, we've got in Africa, we've seen cases reduce quite substantially since the year 2000. We've seen even greater reductions in deaths. So you can see this in the bottom plot in the middle. You've seen really nearly a third of the deaths that we used to have in the year 2000. But worryingly, over the last couple of years, these advances have plateaued. And certainly, according to the World Health Organization, there hasn't really been any sustained decline since 2019. And actually some potentially increase in the number of deaths from this report. And I think we have to talk about this in the light of funding, because on the right-hand side here, I've got a plot of the global funding for malaria control. And you can see that big increases in the early 2000s, but pretty much things have stayed constant ever since. And part of the reason why we're getting this plateauing in the number of cases and potentially increasing the number of cases is somewhat because of this kind of plateauing of funding. And we can't see this changes. The Global Fund, which is an organisation that distributes an awful lot of malaria control interventions, they just had their latest round of funding, and though there are some good news, there doesn't seem to be a big increase in the amount of money that can be spent on malaria control. So this is something that is obviously very concerning, because the burden of malaria is still very intolerably high, particularly in Africa. But what we have to start thinking about is actually health reporting is often very poor in Africa. And I started this project in Burkina Faso in about 2012, where we were looking at a number of reported cases of malaria. And what we've seen over the last 10 years, actually a substantial increase in the number of cases that are reported to the national health system. And part of the reason for that is over this time, the health system in this community has improved. And so as health systems improved, inevitably the number of malaria cases improved. So we can't necessarily use reported cases to understand what's going on. So historically, and this is work that's been primarily driven by the Malaria Atlas project, which are out of Australia, a group led by Pete Gething. We use geospatial models to understand what the current trends are going on. And so these geospatial models, they combine all the kind of the data that there is available. Most of it comes from prevalence surveys that come from DHS, the Demographic Health Systems. And they combine that with satellite maps and cutting-edge machine learning methods, and effectively find a statistical association between malaria and how it's changed over time. And because routine health systems are not necessarily trusted to report reliably the number of malaria cases in most countries in Africa, we use these geospatial models to do it. And actually, if you start looking at these geospatial models, you'll see that they predict in Burkina Faso that there's actually been a substantial reduction in clinical cases over this time. And they generate maps which look really good and are excellent. And you can see, for example, at the bottom, we have malaria prevalence in the year 2000, we have malaria prevalence in the year 2020, and there's been a big reduction over that period of time. And the Malaria Atlas project have statistically shown that the major impact of this is because of the increased distribution of bed nets. And so on the right-hand side here, we have a map showing the current distribution of bed nets and the percentage of people that slipped under a bed net the last night. And you can see that in large swathes of Africa, an awful lot of bed nets are being used. However, it's worth remembering that these are geospatial models, and the data behind these models is often very scant. And so ultimately, these models are useful, but we can't overly interpret them, because effectively, if you look at a country, for example, the size of Ghana or a country like that, the actual number of data points each year that feed into the models are actually relatively small, certainly less than the thousands. So therefore, it's actually the amount of data that's in here. These geospatial models are about as good as they can possibly be. They really are cutting edge, but they can't work wonders, and the data behind them is often relatively sparse, relatively poor. And so we have to interpret these models, which look really accurate, with a degree of potential skepticism when looking at short-term trends. So what's going on in malaria prevention? Well, as I mentioned, the Malaria project shows statistically that the major impact is through the distribution of insecticide-treated nets. And you can see on the plot on the right-hand side, something I drew the other day, just showing the increased number of nets distributed each year across Africa. And we know that over 2.5 billion have been distributed since 2000, and each year, last year, over 250 million were given out. The majority of these nets over this period of time have been something called pyrethroid-only ITN. So these have just got one class of insecticide on them, the pyrethroids. We have starting to see some other types of nets being distributed, and I'll talk a bit about those later. We also have indoor residual spraying, which is very effective but quite expensive. There they spray insecticide on the side of walls. We have seasonal malaria chemoprevention, where effectively we give children drugs a number of times during the transmission season in areas of seasonal transmission, and that reduces disease burden. And that's the main thing we've had to date for controlling of the disease. Recently, we have the WHO recommended a vaccine, which is absolutely great. But just to put this in perspective, the vaccine might be very good at, well, it's partially effective, and you have to give people top-up doses every couple of years if you're going to have a high level of protection. And even then, the efficacy is still in the kind of 40 or 50%, if you're lucky. And so, though we have a vaccine, the actual numbers that are distributed are relatively low, and its impact on transmission is actually really very low, because the vaccine might be good at saving lives, but it's not particularly good at halting transmission. And so, though we have a vaccine, and hopefully we'll have more vaccines to come, and they're going to be an important part of it, just because we have a vaccine doesn't mean that the malaria is cured. Because it's very expensive, it's going to be hard to distribute, we haven't got enough doses of it, and it only can be used on top of all the other vector control programs that we have going on. And so it's an important tool to have, but it's no way a silver bullet. And the majority of malaria control is going to still to be done through controlling the mosquito vector. So the World Health Organization has identified a number of threats. I'll start at the bottom here. We have parasite resistance to the drugs. We have also, interestingly, we have resistance to the diagnostic views out there. And both of these are super interesting. I'm not going to talk about them today, partly because it's quite obvious if somebody has drug resistance, they don't get better. It's not so obvious if they have diagnostic resistance, but you give them another diagnostic and they get better. What I'm going to talk about is two kind of other threats that are real and very pertinent at the moment for malaria is insecticide resistance. So this is mosquitoes becoming resistant to the insecticides that we use. and also invasive mosquito species into Africa. And I'm not going to talk too much about this. I think it's a huge problem. There's obviously Anopheles stevensii is a major vector in India, but in Africa, malaria is much more of a rural disease because they don't have vectors like Anopheles stevensii, which can live inside perhaps more polluted areas in towns. And in recent years, we've seen we've seen the invasion of Anopheles stevensii into the Horn of Africa. It's now been identified in as diverse locations as Ghana, Nigeria, Kenya. And so there's a real fear that in the past, malaria in Africa was a rural disease, but in the future, it could be an urban disease, which would cause huge potential problems. And we've seen a huge surge in cases in places like Djibouti, which were nearing a malaria elimination. And similarly, fear. We've done some modelling which predicts that actually malaria cases, for example, in Ethiopia could double if they had similar levels of Anopheles stevensii. Ethiopia is incorporate as a threat climate change into this, and there's an awful lot of talk about how climate change might be influencing mosquito behavior, mosquito physiology, and increasing the range at which mosquitoes can transmit disease. And I think there's no doubt about it, it is a threat. Quite how complex it is to understand how climate change will impact malaria, I think it is something it's far too early to say. Yes, true, mosquitoes do need water to lay their eggs, and a lot of the processes inside the mosquito are regulated by temperature, and therefore, you know, we used to have malaria in the UK, but it was so damn cold that the mosquito died before the parasite was able to transmit. Obviously, there is links, but I think it's too early to say. Malaria will probably go up in some places, probably go down in other places. So I think currently the kind of threat of climate change is a threat, but it's far too early to say whether it's going to have a substantial public health impact. But mostly I'm going to talk today about insecticide resistance. So in the past, when we had a cup of mosquitoes, we get a cup of mosquitoes and we put them against a bed net. Now, as I said, all bed nets up to this point have been with this one class of insecticide, the pyrethroids. And in the past, you put a couple of mosquitoes against a pyrethroid bed net, they would all die. Now you do that in some areas of Africa, and the kind of mosquitoes look at you and go, oh, come on, then what else have you got? And none of them die. So this is clearly a kind of issue. But the importance of this issue perhaps has been a little bit understated, because the majority of control has been using insecticide-treated nets, and people look at insecticide-treated nets and they think, oh well, the main job of an insecticide-treated net is to provide a physical barrier between you and the mosquitoes that bite at night, and therefore it protects you. So when people started reporting insecticide resistance, it became there was this kind of debate as in, is this a problem? Clearly, it's not a good thing, but if people are sleeping under bed nets, and our models predict that about if you have 80% of people using a bed net, then 60% of the benefit of that net is actually from the insecticide. What does that mean? This actually comes from quite a hard exam question that I was once set as, is it better to be one person in a village? Now, the answer to that, I think, is certainly the one person in the village without a bed net, because effectively what the bed net does is it acts as a distribution of insecticide. People are sleeping under bed nets, they act as bait. Mosquitoes come in and they try and bite you, they hit the bed net, they take up a dose of insecticide, and if they're not resistant, they die. Now that provides protection, not just for the person sleeping under the bed net, but for the whole community. And so if you have a lot of people using bed nets, you get this thing called community protection, which means effectively mosquitoes are all dying at too fast a rate for actually the disease to spread quickly through the community. And so the models that we've generated, you can see here, I break down the benefits that you get from a bed net, and you get direct benefit from the barrier. And if you're a single user, you get about 30% protection from the barrier itself. But you also get indirect benefit, and indirect benefit is because effectively, if I don't have malaria, then there's less chance of me giving it to somebody else. And so that lowers the force of infection in the community, and you get the benefit that way. And so if you have one user, you get very little indirect benefit. But if you have 80% of the population using a bed net, then you have quite a lot of indirect benefit just from that physical barrier. Now you add the insecticide, and you get the added benefit of the insecticide and the barrier. You start seeing really big impacts, and actually, as you start moving to higher usages in the community, then the vast majority of the protection that people provide, the vast majority of avoidance of malaria, is because effectively everybody else is killing the mosquitoes around you. They're not transmitting, and therefore you are protected, even if you are not using a bed net yourself. Hence that rather tricky exam question that I was given years ago. But one of these things is quite difficult to show, because we can't really randomize resistance. We can't really randomize mosquitoes between communities. And the majority of the kind of gold standard data that we use to understand what's going on is cluster randomized controlled trials. And so though we know mosquitoes are not dying anymore, it's taken us quite a while to kind of generate the narrative that actually this is a real public health problem. So, what's going on about it? So, what we do, we as a kind of group, and I'm saying we here, there's probably about 30 or so scientists working at Imperial on this. It's an immensely complicated disease, and so actually characterizing these things is very, very difficult. What we do is we turn the lovely biology into this mosquito and parasite and human system, and we simplify it down into effectively states. We make compartmental models where we classify people as, for example, susceptible or asymptomatic or patent, or having clinical disease or untreated clinical disease, and so on. We kind of classify people into different ways. Similarly, we classify mosquitoes being susceptible, infected, infectious. And we also capture the dynamics of the mosquito life cycle as well. So we offend everybody by effectively simplifying this. And it looks simple in this model. It's not. We have to take into account lots of the factors that govern malaria epidemiology, which is such as immunity. Human immunity is immensely important, and heterogeneity in biting. So some people are bitten more than others, and some not. And so all of these things, though it looks quite a simple model, is actually really quite complex. And then we need to think about, well, actually, how do mosquito bed nets actually impact this life cycle? Firstly, they kill mosquitoes. They reduce biting, so they reduce the infection process. They reduce the number of mosquitoes able to transmit. And they also potentially reduce the number of eggs that are out there, so you have fewer mosquitoes. If more mosquitoes are dying, you have fewer laying eggs and fewer new mosquitoes developed. And so what you have is an intervention that actually has lots of impact on lots of different parts of the life cycle of the parasite. So this is the other nimri I was talking about earlier. This is an example this is Basiliana and Manju from Mwanza in Tanzania. And they're standing outside an experimental hut trial. And this is a really great real-world assay that we use to parameterize our models. So what we have here is these kind of fake houses built in the local style. And inside those houses, we have people sleeping under bed nets. And under bed nets, we put the bed net that we want to test in that location. We put holes in the bed net, and mosquitoes free flying around this area will enter this house and try and bite people underneath these bed nets. What we have is inside those, we have multiple of these houses next to each other. And so in those houses, we have sometimes we have intervention, we have bed nets, sometimes we have spraying on the side of walls. We might have different types of bed nets. And we capture the mosquitoes, and as if ever you've seen a mosquito fall on the floor in Africa, it doesn't last very long. It's generally snaffled up by some ants and eaten or something. So we have these ant traps around and we have these kind of eave traps that stop mosquitoes from exiting the house afterwards. So this is actually a veranda trap here. And so the idea is that somebody sleeps underneath this bed net each night. Mosquitoes naturally enter, and then they get killed by the bed net, or they blood feed, or they exit, and we can use this information to determine what's going on. So this kind of gets us some really nice raw data like this, and we can see here the number of mosquitoes caught per night. We have, and this the study went over 40 days, and you can see the number of mosquitoes caught per night and what status they're in. This is a control intervention, so no intervention, and this is the a type of net that has insecticide on it. And you can see from the control hut, first of all, looking at the force of infection is huge. Some people are bitten over 30 times. So this is the number of mosquitoes that come in a hut per night, and how many of those are actually successfully blood fed through the bed net. This is a control, so this is no insecticide on that net. But you can see the force of infection in this area is huge. People are being bitten by potentially 30 mosquitoes a night, and 5% of those might have the parasite. And so you can see how you have to have really good effective malaria control if you're going to stop somebody from getting disease. What we also have here is the different arms of the study that we do in this one here. We have the numbers of mosquitoes that die are much greater in the nets with insecticide, and you can characterize the behavior of the mosquito from these different huts. And you can see that a large percentage of the mosquitoes, you get many more mosquitoes in the huts without the insecticide than with the insecticide. So the insecticide stopping mosquitoes from entering. But similarly, you get not a huge amount of death in some of these things. So in this scenario, you have about 30 to 40% of mosquitoes are actually being killed at the time in that net. So what we can do that is we summarize these kind of interventions, and then we move them. We use these to parameterize the mathematical model, and we've collected experimental hut trial data from all across Africa, and we collect it all together. We do a meta-analysis. We summarize how, for example, the effectiveness of the bed net changes over time, and then we use this information to parameterize our mathematical model. And we test our model's ability to do this by effectively trying to recreate the results of cluster randomized controlled trials. So we fit our model, we parameterize our model with all the mosquito data, we move it forward, we hit this data point there, and then we see how well we can capture the different arms of cluster randomized controlled trials here. So here's a trial which just has bed nets, and here's a trial, the yellow ones, where we have IRS, so indoor residual spraying. And our ability of the model it kind of provides some level of validation that our model is working. And so what you can see is that, broadly speaking, our model is able to recreate the results of the cluster randomized controlled trials. So you can see on the x-axis the transmission model predicted prevalence, and the y-axis is the observed prevalence. In an ideal world, all the points would fall along the line. But what we see is, broadly speaking, our model is able to capture the dynamics in different settings from these different cluster randomized controlled trials. So what that allows us to do is effectively use these models then to predict the impact of resistance in different countries around the world. We measure resistance using discriminatory dose assays, so cups of mosquitoes, and we can then combine this information with the model to predict what impact different nets are having in different locations. Now, the good thing about malaria is there's no shortage of potential tools to do. And so another part of the things that we are doing is evaluating new vector control tools. Currently, as I said in the past, there was very limited. We were just limited to different types of insecticide-treated nets. But now we're starting to get different types of vaccine, different types of drugs, lots of different interesting ways of killing mosquitoes, potentially genetically modified mosquitoes. All those kind of things are in the pipeline. So what we do is we use our models to try and see what the public health impact of these particular inventions would be in a particular place. So a recently funded project, the UNITAID funded project, looking at a new type of insecticide treated net with two types of insecticide on. Here you have both pyrethroid out, but also you have another insecticide called a pyrrole. And so you've got two insecticides to kill mosquitoes here. And so what the new Nets project did, it did pilot implementation programs in lots of different countries, Burkina Faso, Nigeria, Rwanda, and Mozambique. And what we did is we collected all the entomological data we could get from different sites, different experimental trials across the world. And you can see here the mortality on a pyrethroid only net and the mortality in the next generation net. That's either a pyrethroid PBO net, which is this one here, the purple one, or a pyrethroid pyrrole net, which is this green one here. And because the points are generally above the line, these mosquitoes are killing more mosquitoes than a pyrethroid only net, showing both the importance of pyrethroid resistance, but also on the importance of pyrethroid resistance, but also how these new nets can be used to kill mosquitoes better. So what we've been doing is we've been trying in these sites where they trialed these new nets, we've been trying to see if our models can recreate the dynamics of what's going on. And this was seen over the last, so that we've been doing this over the last 2 or 3 years. And last year, the first cluster randomized controlled trial of this new net was trialed in Tanzania by Moshe et al. And Natasha Protopopova to try and improve these fits. Currently, we're just predicting at the arm level, but hopefully we'll be doing predictions at the cluster level, which might be better moving forward. So what help people make that decision? You've got this tool. This is work developed by Ellie Sherrod-Smith and others. But what this is online, and this is for national malaria control programs. And what they can do is they can put in the environment which they're in. They can put in the details of the mosquito species they're in. They can put in details of the history of vector control. And that would allow the model then takes, and you can put in cost information. You can put in how many, what kind of usage you would achieve for a given number of nets distributed, and the cost of the nets, and the cost of the different vector control interventions. And you can combine that together, and the model will show you what it thinks would happen in that location, given if you distributed those different types of nets or did IRS. And you can see here, if you did nothing, you would have this grey line, and if you had pyrethroid only, you would do this to malaria prevalence. And if you did the pyrethroid pyrrole net, this new net, you would do better. And you can use the model to estimate the number of cases averted that we predict would happen from that. And that just allows us to do cost effectiveness analysis. And you can see that actually, even though these nets are much more expensive, the actual cost per case averted is substantially better. So there's still lots of important decisions to be made about how you should use these nets, where you should allocate them. But this provides a framework for which people can start looking at and taking information from their local mosquito species, because obviously this varies according to the level of pyrethroid resistance you have in the mosquito species, to allow you to actually tailor your control to a particular area. And then finally, we allow resources to be allocated across regions. So the tool also allows us to put inputs from multiple different regions, and then multiple different regions, and then we can use the algorithm to work out what's the most optimal allocation of resources across those different regions to avert the most cases. So you can see if you had a budget of, and you have 3 different regions in this situation with different levels of malaria, different historical use of interventions, different levels of resistance in the mosquito population. If you had a budget that was, say this, for this size population, you would probably do IRS in one of your areas and then do pyrethroid pyrrole in the others. And if your budget went down, then this kind of shows you where you would spend your money to avert the most number of cases. Obviously, there's lots of other things that need to be considered in that. Local preferences, we need to talk about equality or equity and how best to do that. But hopefully this framework will help provide a tool to help people explore what's the best thing to do then. It can't provide the answers, but hopefully it can provide a tool to help make people make these difficult decisions about what's the best vector control to do in that location. And to kind of end on a good news story, as in these new nets. So you can see this is a figure similar to one I presented before, where you can see the increase in the number of nets distributed each year. That was up to now. And in the last couple of years, you've started seeing these pyrethroid PBO nets, which have a synergist attached but are not that good. And then the increase in the number of pyrethroid pyrrole nets that are being used. And you can see that the projected increase in this over time is, now that it's got a WHO recommendation, is huge. And we use these to estimate what benefit you would have of switching to this new type of net. And we think on both cases averted and slightly more uncertain deaths, but we think that adopting this new type of net could have substantial impacts on reducing deaths in the year to come. So with that, I will really stop and thank funders, and particularly the Essentials programme, which has got collaborators all over Africa that have been doing these experimental trials.
Tom, I have a quick question to you. You talk very beautifully about the alliance, and you also talked about non-pyrethroid alliance, and especially with the PBO. You showed the graphs of PBO net, that permanent 3.0, and you in general talked, and then you showed in the end one slide where you were putting all the parameters which should be taken into consideration when we are switching from pyrethroid to other nets, like resistance, prevalence of malaria, coverage, and cost effectiveness. I want to ask, this is a very tricky question for India. So the India situation is a little different from Africa. It's very different rather. So we have done few trials with the PBO net, with the trial with a net called Viral, which is a PBO net, but the resistance levels are not as high as to justify the switch from a regular pyrethroid net to a PBO net. So the national program will not take it because definitely it's costly, and you are adding one more layer to it. So when do you make this decision? What should be the countries be guided with? When to switch on to a supplementary net or a non-pyrethroid net? I understand resistance will be one of the major factors, but what about country like India or other countries where the data of resistance also is not very systematically collected, and it's sparsely available? How do you make these decisions on resistance? Number one. Number two, the WHO documents are always, in the end, they will say that these decisions need to be guided by the epidemiological scenarios of the country. Even if the resistance is found on susceptibility tests in the laboratories, that doesn't mean that the net is not working. So, and how do we select whether to select a PBO net or a pyrethroid net? Or now there are other nets also, clothianidine, I don't know how to pronounce those things, but these other nets also are there, and they are getting WHO pre-qualified. And now there's a big push, even by global funds and WHO, to switch on to non-pyrethroids alternatives. And how does a country like India, where the malaria is on decline, how do we address this question of switching on to other nets?
So I think it's immensely difficult, and I agree it's a really difficult decision, because pyrethroid-only nets are still working well, even in Africa, but they're not working as well as some of these new nets because of pyrethroid resistance. I suppose my feeling is that pyrethroid resistance in India is only going to get worse. It's not going to get better. There's so many pyrethroids in the environment that it's going to get worse. And I think ultimately, unfortunately, it comes down to local entomology, and you have to have local entomology that tells you about the level of resistance to know whether you have to invest in that net. And our techniques for entomology, as you guys know much better than I do, are it's expensive, and there are lots of variability. Mosquitoes either all die or they don't all die, and it's very, very complex. But I think ultimately you need to have evidence of pyrethroid resistance in the local population, and I think if you have that, even from a discriminatory dose bioassay, then that justifies spending more money on nets, because those nets will be working better. And I know budgets are limited, and national malaria control programs can't do everything everywhere. But I think if you have the data from the mosquito population that says, look, this net would be working substantially better, you could then use the tools like we presented to say, look, this is going to, if we switch nets, that's going to avert X thousand lives. And so even though the nets were already working somewhere, we can do better if we have that new net. And I think that's, we have to argue with, for increasing the budget, not just for reallocating the budget. And I think converting it, because when drug resistance fails, it's really obvious people are ill. When pyrethroid resistance appears, it's not very obvious because people slowly get more malaria. It's not quick, and there are lots of other things that could be causing that. So I think we need these tools to try and convince policymakers that we can spend more money on these more expensive nets. But it is difficult.
Right. Tom, if you allow one follow-up question, and I'm very tempted to ask you several questions. Can there be a simplified answer, biomodeling method or something like that, where you define the level of resistance as a decisive factor when we switch on to other than pyrethroid net?
So I think that, like, if you had no money problems, you would do it immediately, because as soon as there is pyrethroid resistance, the bed nets would be working less well. Obviously, the more resistance you have, the more of a need to switch. And so therefore there isn't a simple answer, unfortunately, because it's how much money can you get out of your budget. So unfortunately, I think that's why the WHO go, it's down to the local setting, because if you have the budget, you would do it. If you don't have enough budget, then you have to do as much as you can and put the budget where you do have potentially better net, use your better nets in areas of higher malaria and higher resistance. And again, I think this tool could help you go, well, if I've got this area with low resistance but high malaria, is it better to put the more expensive net in there, or is it better to put it in an area with low malaria but high resistance? And
the situation in India is very peculiar. So you are raising the point of affording an expensive net. So that is an important factor. But imagine a country like India where we have some information of resistance, but it's not uniform across the country. India is a vast, heterogeneous country with multiplicity of vectors, and the type of ecotypes we have, several. It's very difficult to reach a consensus that this level of resistance, does it qualify for a switch or not?
Yeah, I agree. It's really complex. It's really complex, and that's why you need good entomologists to be able to show that the nets are not working to justify the extra budget. It needs that work. Yeah.
Right. Thank you for that. Thank you.
Thank you.
Sachin, any other question around?
Yes.
And my question is that what about the cryptic species of Anopheles? There are many cryptic species, those who are playing a role in many, additionally with the principal vectors like Funectas and all these things. So I just reviewed an article from Nigeria, I think, Kenya. They have mentioned about the cryptic species, what is very, very important about. So you have to highlight on the cryptic species of disease transmission, especially malaria transmission, when you are going for elimination.
Oh, completely. I think lots of places aren't quite at the level of elimination yet. So I think a lot of the decisions at the moment can be made on the kind of primary mosquito species. But as you say, as those are controlled, then these other little species kind of pop up and can have a huge impact on malaria at that point. And so, yeah, it's really interesting evolutionary and how these cryptic species build together. It's a really interesting field to be in, and it all comes down to entomology in the end. Which is really interesting.
Thank you very much, Tom. And we would like to conclude this talk with one of my comments, because you talked about the budget. We would like to see your predictions for the global funding to eliminate, malaria globally. If you can, do some mathematics and come up with the prediction model for the global fund, if possible.
Yeah.
I don't know. But thank you very much. Yes.
It will definitely be wrong, but we're trying.
Yes.
We'll try. We'll try.
Yeah. Okay. Thank you very much for joining us, and I thank you from from the MERA-India team, and on behalf of National Institute of Malaria Research here in Delhi, from Indian Council of Medical Research, and from all the participants who has joined us and spent time with us. Thank you very much, and we would like to be connected with you in future as well. Thank you so much.
Thank you very much.